Thank you. Greetings from France. I'm really happy to be with you today for discussing about breast cancer. And so we're going to start with the HER2 positive metastatic disease. Here are my disclosures. And I will start with a revolution which occurred at the beginning of the 2000s. I mean, trastuzumab, Herceptin in combination with chemotherapy for the metastatic disease. And in some phase 3 trials, Herceptin was combined with adriamycin or epirubicin and cyclophosphamide, and in another trial was combined to paclitaxel. And whatever the combination with a cytotoxic agent, we have progression-free survival benefit in all those trials, and an overall survival benefit in the trial with anthracycline. However, as you know, it's impossible to directly combine trastuzumab with an anthracycline due to the potential cardiac toxicity. So the standard at the beginning of the 2000s was the combination of trastuzumab and paclitaxel. And you can see that we have an overall survival rates around 25, 26 months. And those data have been considerably improved in the coming decades, as we will see. You can easily combine trastuzumab with any cytotoxic agent which works on breast cancer. I mean, paclitaxel, preferably weekly paclitaxel, but also docetaxel, but also vinorelbine. And there was an interesting phase 3 trial named HERNATA, which showed that vinorelbine did as well as docetaxel when combined to trastuzumab, with similar results in terms of PFS and also a slight advantage in terms of OS in favor of vinorelbine, which is probably better tolerated than taxanes. But you can also combine trastuzumab with hormone therapy. This has been done in the phase 3 tandem study. However, the results were relatively disappointing. There was a significant benefit for Herceptin in combination with the aromatase inhibitor versus the aromatase inhibitor alone, but the difference was only around 3 months in terms of PFS, and there was no meaningful difference in terms of overall survival. So clearly disappointing results, which means that you have to combine, before all, you have to combine trastuzumab with chemotherapy for treating patients with metastatic disease. We also have a small molecule, which is a tyrosine kinase inhibitor, which is lapatinib. And this agent is relatively active against HER2 positive tumors, and it was combined with letrozole in this study, phase 3 study by Blackwell and Johnson, and we saw a benefit in terms of PFS, which made that the study was early terminated, and unfortunately we saw no benefit in terms of overall survival. So the standard was the combination of trastuzumab plus chemotherapy, and some options, in particular with elderly patients or more fragile patients, could be a combination of hormone therapy and either a trastuzumab or lapatinib. However, when you combine lapatinib with chemotherapy, and if you compare with trastuzumab and chemotherapy, there is a superiority of the combination with trastuzumab over lapatinib for the treatment of the metastatic disease. So trastuzumab remained the reference agent in this context. However, despite very interesting advances in terms of survival, symptom controls, and overall response rates, we can see some mechanisms of resistance to trastuzumab. And the main mechanism of resistance is heterodimerization of the HER2 receptor with other receptors from the EGFR family, namely HER1, which is EGFR, HER4, HER3, but the most important mechanism is the dimerization with HER3. And so it was interesting to block this mechanism of resistance. And on the right part of the slide, you can see that the monoclonal antibody pertuzumab can bind to HER3 and HER2, and then can inhibit the mechanism of resistance, can inhibit the heterodimerization, and we will see that we have a proof of concept in the CLEOPATRA trial. And another way of overcoming resistance to trastuzumab is combining a monoclonal antibody, which is trastuzumab, and a chemotherapy, which is DM1. And you have the TDM1 or Kadcyla, which has both advantages of HER2 inhibition and chemotherapy. And so you have a cytotoxic effect. The drug will bind to the HER2 receptor and then will be internalized into the cell and will block the HER2 pathway and also have a cytotoxic effect. And finally, it also activates the ADCC. Regarding pertuzumab, we have this very important phase 3 trial, which is CLEOPATRA. And in this trial, the reference arm was the combination of trastuzumab and docetaxel. And in the test arm, pertuzumab was added as it is indicated on this slide. We had more of 800 patients included in this trial, and they received at least 6 cycles of chemotherapy, but maybe sometimes more, and they were treated until progression. We had an important PFS benefit in this trial, but I'm just showing you here the most recent data regarding overall survival analysis, and you can see that the delta is really impressive. It's more than 1 year in terms of median of overall survival between pertuzumab, trastuzumab, and chemo, and trastuzumab and chemotherapy. So it was a major advance in this context. And we have some other data showing that if you give docetaxel in combination with trastuzumab, pertuzumab, or weekly paclitaxel or nab-paclitaxel, you will obtain, I would say, roughly the same results in terms of progression-free survival. So the combination is possible with all those agents, and also with vinorelbine, that was shown in the phase 2 VELVET trial. So can we also have a benefit when combining pertuzumab and trastuzumab to hormone therapy? It was assessed in the PERTAIN phase 2 randomized phase 2 trial. In first line, it was a strategy trial, and the patients received docetaxel or paclitaxel, then an aromatase inhibitor, plus pertuzumab and trastuzumab, both with chemotherapy and with hormone therapy. And in the control arm, chemotherapy plus trastuzumab, then the aromatase inhibitor plus trastuzumab. And this trial is positive in favor of the combination of pertuzumab and trastuzumab to chemotherapy and then to the maintenance treatment with the aromatase inhibitor. But you can see that the difference in terms of PFS is relatively small. So it was probably interesting to see if pertuzumab could be combined to TDM1. It was done in the MARIANNE study. More than 1,000 patients in first line were included in this trial, and we had a comparison between trastuzumab and docetaxel or paclitaxel. In the second arm, TDM1 alone, and in the last arm, which is probably the test arm, TDM1 plus plus pertuzumab, and PFS was the principal endpoint. As you can see on this slide, there was no obvious benefit in favor of the combination, which indicates that the reference treatment remains the combination of a taxane and trastuzumab and pertuzumab, and T-DM1 seems to be the best agent, not in first line, but in second or third line, as we will see. So what about anti-HER2 treatments in second line? We have seen this small molecule, lapatinib, with tyrosine kinase inhibition on the intracellular domain of HER2, and in this trial by Geyer and collaborators, lapatinib was combined to capecitabine versus capecitabine alone in patients who had previously received anthracyclines and taxane. And as you can see, there was a PFS benefit in favor of the combination, but no overall survival benefits. So I would say in the middle of the 2000s, the combination of lapatinib and capecitabine became the standard starting line with the second line. However, other teams have tested the combination of capecitabine, named Xeloda, capecitabine and Herceptin, versus capecitabine alone in second and third line. And as you can see in this German trial, there was a benefit also in favor of the combination. So you could choose between capecitabine and lapatinib, and also between the combination of capecitabine and Herceptin. And in this context, we have this combination, including T-DM1, Kadcyla, against capecitabine and lapatinib in patients previously treated by anthracycline and taxane. And PFS was the principal endpoint of this study. And in this phase 3 trial, the progression-free survival, as assessed by an independent review committee, was higher for T-DM1, higher than with capecitabine and lapatinib, and the difference was approximately 3 months, and it was statistically significant. There was also a survival benefit, which is important to mention because we are beyond the first line. On the waterfall plot, we can say that the most important benefit is certainly observed in patients with the most aggressive disease and with, for instance, with visceral involvement. No other major difference except that you can see what you can see here. The benefit of T-DM1 is observed as the first line treatment, a second line treatment, and the third and later line treatment. In the Teresa trial, the authors tested T-DM1 against physician's choice chemotherapy in more advanced line, we could say in a palliative context. So treatment of physician's choice with various possibilities of treatment. 600 patients included in this trial. They should have received at least 2 lines of prior HER2-directed therapies. And there is also a meaningful benefit of 3 months in favor of Kadcyla, and also in patients who previously received trastuzumab-containing regimens. And also a significance around 6.5 months in terms of overall survival benefits. So T-DM1 is the reference treatment beyond the first line, in second, third line, or even after, if the patients did not receive this drug before. So what is the interest of lapatinib and trastuzumab without chemotherapy in more advanced lines. In this trial by Kimberly Blackwell, we can see that the combination of lapatinib and trastuzumab was more efficacious with a PFS benefit in favor of the combination, more efficacious than lapatinib alone, and there was I would say a meaningful benefit, but it was mainly driven by the population of hormone receptor negative patients, and this is an option which is valid for this subpopulation of patients with hormone receptor negative tumors. So trastuzumab is at the end is still the pillar of the strategy. It can be given also in combination with vectorized chemotherapy, for instance, TDM1 in the Emilia and Teresa trial. And it's better, it's more efficacious than lapatinib and even trastuzumab chemotherapy combinations. And after TDM1 progression, you can choose perhaps between lapatinib and capecitabine, or the combination of trastuzumab and lapatinib, which is probably less toxic, in particular with patients with hormone receptor negative tumors. We have, however, new interesting strategies. You can try to combine trastuzumab or TDM1 with immunotherapy on the basis of in vitro models showing a potential synergy. However, we have some preliminary disappointing results, which I will not show in details because we miss time. In the Panacea trial, the patients were resistant to Herceptin, and they received a combination of trastuzumab, again in combination with an anti-PD-1, and unfortunately the results were not significantly different. And in the Kate trial, there was a combination of TDM1 and atezolizumab, and PD-L1 inhibitor agent, and in a randomized manner. And there was unfortunately no significant difference by adding the immune checkpoint inhibitor. We have also this interesting randomized phase 2 trial, which is the Monarch Hair trial, which was presented by Sarah Tolanet 1 year ago at the ESMO meeting. And in this trial, we can see that the combination of trastuzumab and fulvestrant and abemaciclib is better than the combination of trastuzumab and abemaciclib and trastuzumab and trastuzumab alone. Sorry, and so this is probably a promising combination, but which needs a confirmation in a phase 3 trial. But the most interesting agents are probably now other tyrosine kinase inhibitor. Not necessarily neratinib, which looks like probably lapatinib, and which showed a small benefit in combination with capecitabine versus the combination of lapatinib and capecitabine in the NALA trial. But I think the most interesting drug is probably tucatinib. In the HER2CLIMB trial, we will see the results coming. And another area of research is antibody drug conjugates, and we have the trastuzumab deruxtecan with the DESTINY program, and the trastuzumab duocarmycin currently in the TULIP trial. So if we have the example of trastuzumab deruxtecan, we can see that it's a combination of trastuzumab, and we have a cleavable linker, but also a chemotherapy, which is deruxtecan, which is an analog of irinotecan and also of topotecan. And what about the mechanism of action? Of course, the molecule will bind to HER2, then it will be internalized just the same way as TDM1. And then you have a linker cleavage, then the chemotherapy will be released into the cell, but it will also get out the cell and be able to act on other cells, what we call a bystander effect. And probably you can have some activity on other cells who do not have a significant HER2 overexpression in the context of the tumor heterogeneity. Those tumors are called HER2 low, or those cells are HER2 low, and you can have some activity of the drug in this context. The efficacy was assessed in a phase 1, in a big phase 1/2 program, which was recently reported, as you can see, in order firstly to assess the best dose to give to the patients. But as you can see, this waterfall plot is really impressive. There was a very, very, very high response rate. Almost all patients responded at the dose of 5.4 milligram per kilogram. So it's really a promising drug, and now we have this program, which is the Destiny program, and the drug is being tested against TDM1 in second line. It will be tested against chemo and Herceptin in first line. It's tested as a neoadjuvant treatment. So we have a very, very large program of clinical trials with this drug. We have the same, but a smaller program with the trastuzumab duocarmycin, and we currently have the TULIP trial testing this drug against TDM1. Regarding tucatinib, we have the HER2CLIMB study, which is also very interesting. This randomized study compared the combination of tucatinib and trastuzumab and capecitabine against trastuzumab and capecitabine in advanced lines where patients had previously received both anthracycline, taxane, and TDM1. And the results are overall in favor of the combination, with no subgroup having no benefit from the combination. And you have a benefit in terms of progression-free survival, but also in terms of overall survival, which is really interesting. We have around 4 to 5 months overall survival benefit, but certainly the most fascinating is the results obtained in patients with brain metastases. Indeed, patients with active brain metastases who were not necessarily controlled by radiotherapy or surgery could be included in this trial, which is not the case in almost all the trials. We can see that at 12 months since randomization, no patient in the reference arm is free of brain metastasis progression, as compared to 25% with the combination of trastuzumab, capecitabine, and tucatinib. So what we can say is that HER2 positive tumors have moved from the worst to the best prognosis in 2 decades. And to date, we can say that around 25% of patients are now free of progression 5 years after the beginning of their treatment, for instance, combining chemotherapy, pertuzumab, and trastuzumab. And it's not doubtful that some patients with metastatic disease can be cured. We can see in the literature some series of patients having stopped their treatment with a follow-up of more than 10 or 12 years with absolutely no relapse. And some of those patients sometimes have benefited from a local treatment of their metastasis, bone metastasis or liver metastasis, for example. And also, the treatment of cerebral metastasis has deeply evolved due to radiotherapy, stereotactic radiotherapy, and also surgery, and now with tucatinib, for instance, with medical treatments, or also patients with cerebral metastasis can have a very, very long survival. So in those patients, overall, we need to be ambitious in order to have the best possible overall survival rates. So I have finished with this talk, and I thank you for your attention. Perhaps we can move to the talk about luminal tumors, if you agree. And perhaps
that will be perhaps better if you continue with your talk.
Okay, you want me to stop the talk now? Okay.
No, you can continue.
I can continue. Okay.
Yeah.
That's fine. So now we are moving to a very different topic, which is luminal tumors, metastatic luminal tumors overexpressing the hormone receptors. So just to remind you that we have some very well-known prognostic factors with those tumors. The main prognostic factors are performance status, site of disease, visceral metastasis, and central nervous system metastasis are linked to a poor prognosis. The number of metastatic sites, of course, the positivity of hormone receptor is a good prognostic factor. HER2 overexpression is an unfavorable prognostic factor. However, as you know, it will be transformed into a very good prognostic factor when you give anti-HER2 agents. And also the disease-free interval from the initial local regional treatment. And the prognostic is also better in patients who did not receive a prior adjuvant therapy and also a prior therapy for the metastatic disease. Let's go back to the tumor biology, because it's really important, I think, to understand the new concept of treatment. The tumor cell signaling with the estrogen receptor pathway is a bit complex. I would say you have what we call a canonic pathway. You have estradiol, which will link on the estrogen receptor, and then the combination, the complex, will have a direct effect on the DNA, favoring, of course, tumor cell multiplication. But you also can have another mechanism which is always dependent, directly dependent from estradiol, which is the link to transcription factors, which can be in relation in a crosstalk with the GF, the growth factor pathway. This is the second pathway, which is called non-canonic. But also you can have other pathways of activation of tumor cell proliferation. You can have a non-genomic activation with the complex, with the estrogen receptor and estradiol complex, which will directly activate, for instance, the PI3 kinase pathway and also the MAP kinase pathway in order to have this effect on tumor cell proliferation. And finally, you can also have a ligand-independent pathway, which is not under the dependence of estradiol itself, with a direct activation on some other pathways, mainly PI3 kinase, AKT, mTOR, and other pathways. So it's a bit complex, but it helps us to understand how our drugs can work in this context. Of course, both ovarian function suppression and aromatase inhibitors will deplete the amount of estradiol and will have this direct effect on the canonic pathways, and also the selective estrogen receptor modulators, such as tamoxifen, will inhibit, they will directly inhibit the estrogen receptors. And we also have other drugs, selective estrogen receptor degraders, which probably will bind irreversibly to the estrogen receptor and certainly destroy it, perhaps having a better effect than the tamoxifen itself. So the most important point is how can we also have an effect on the other pathways? What we know is that we have some mutations on the ligand binding domain of the estrogen receptor, which are hotspot mutations of this ligand binding domain, which will confer to the receptor and so to the cell a natural resistance to endocrine therapy. And we estimate that it's about 20% of luminal metastatic tumors. And the most interesting, as you can see, is that you have a difference between the primary tumor, which almost never express ESR1, and the metastases that can be mutated in around 20% of the tumors, which is not the case, for instance, for PI3 kinase, which is a very important mutation, as we will see. So it's undoubtedly an acquired mutation. Our first question, it's a very important and a question we already had 20 or 30 years ago. Should we start with hormone therapy or with chemotherapy? When you look at the advanced breast cancer, it's a European group, ABC3 recommendations, we can see that they say endocrine therapy is the preferred option for hormone receptor positive disease, even in the presence of visceral disease, unless there is visceral crisis, we will comment about that, or concern or proof of endocrine resistance. Why this statement? We can see in those meta-analyses from the Cochrane collaboration, we can see that when you compare the efficacy of chemotherapy and tamoxifen and LH-RH agonist and aromatase inhibitors, it's before the CDK4/6 era, you can see that you have a small improvement of overall response rate in favor of chemotherapy, but absolutely no difference in terms of overall survival between chemotherapy and hormone therapy. And so we prefer hormone therapy in this context, but because it is largely less toxic than chemotherapy. So endocrine therapy before the CDK4/6 era was the preferred option in first line. And now we are at the CDK era, but once again, before the CDK era, what did we know? We know that aromatase inhibitors are probably more efficacious than tamoxifen on the metastatic disease. If you give anastrozole or letrozole or even exemestane with no substantial difference between those three drugs, you have a PFS benefit over tamoxifen, but not any overall survival benefits. However, aromatase inhibitors in menopausal patients, of course, will become the reference treatments in this context. And around 2008, 2010, we had fulvestrant, which is a third, and the peculiarity of fulvestrant is that it seems to be active on ESR1 mutants. And initially, this drug was relatively badly developed because it was given at the dose of 250 milligrams per month. And we have seen that we could give higher doses without toxicity. I mean, 500 milligrams by the intramuscular route at day 1, day 15, day 29, and then every month. And in this trial, comparing the two doses, there was a dose-response relationship in favor of the higher dose, with a PFS, a small PFS benefit, and also an overall survival benefit. So high dose of fulvestrant become the reference treatment. Then it was interesting to compare the activity of fulvestrant against the aromatase inhibitors, of course, in menopausal patients. It was done in this relatively small randomized trial, and the first trial and the results seemed to be in favor of fulvestrant in first line. And then we have the Falcon trial, and Falcon trial is a confirmatory trial. It's a phase 3 in hormone-naive patients, first line, and of course, hormone receptor positive and metastatic breast cancer with fulvestrant against anastrozole. And in this trial, you mean in ITT, you can see that we have a PFS benefit in favor of fulvestrant. But what is interesting is that this benefit is entirely driven by the cohort of patients without visceral involvement, which means with bone metastasis. So when you have bone metastasis only, it seems that you have a benefit of fulvestrant against anastrozole, but it disappears when you have a visceral involvement. However, this was not a stratification criteria in this trial. So you need to consider that it's only an exploratory analysis in this context. But perhaps if you have a patient with bone metastasis only, perhaps in first line, you can eventually prefer fulvestrant to an aromatase inhibitor. In the advanced disease, we also can target the PI3 kinase pathway, and it was done around 10 years ago with everolimus, which is an mTOR inhibitor in the randomized Bolero-2 trials. And more recently, we have the alpha selective direct inhibitors of PI3 kinase, and mainly alpelisib, which was tested in the SOLAR-1 trial. So what we know is that when you give everolimus in combination with exemestane, you obtain a PFS benefit, which is relatively important. You have more than 60% decrease of the likelihood of progression, and a net difference of around 6 months, but no survival benefit overall survival benefit, in this context. And when you look at the PI3 kinase mutations, you can see that they are not, interestingly enough, they are not predictive of everolimus efficacy. We have so a difference between the treatment with everolimus against placebo, and you can see that there is no major difference when you consider the patients with PI3 kinase mutation or with no mutation. So it's independent from the PI3 kinase mutation. And it's not the case with this direct inhibitor, which is alpelisib, which was tested in the SOLAR-1 trial in patients with metastatic disease. They were divided into 2 cohorts, the PI3 kinase mutant cohort and the PI3 kinase non-mutant cohort. And in both cohorts, the patients were randomized between the combination of alpelisib and fulvestrant, again, fulvestrant alone, and the primary endpoint was PFS. And this, this trial was presented by Fabrice André at the ESMO meeting last year and this year. And this trial was positive in the PI3 kinase mutant cohort on PFS. It was a significant difference of about 3 months, which is not a major difference. And unfortunately, there was no difference in terms of overall survival in this targeted cohort, which is, I think, a relatively disappointing results, because this drug has also some toxicity with hyperglycemia, with liver dysfunction, for instance. I think that the main, the most important step forward is the emergence of CDK4/6 inhibitors. So how does it work? Then we must understand that there is a crosstalk, there is an induction of cyclin D by the estrogen receptor pathway. So you have induction of cyclin D, and then cyclin D will inhibit the function of the retinoblastoma gene, and the retinoblastoma gene is the most important factor which regulates one of the checkpoints, one of the checkpoints of the cell cycle. So cyclin D will be activated by CDK4/6, and if you can inhibit CDK4/6 with for instance, CDK4/6 inhibitors, then you will downregulate cyclin D, and so you will restore the function of the retinoblastoma gene and then restore the checkpoint and the inhibition of the cell cycle. This is the way how those drugs work, and those drugs are abemaciclib, palbociclib, and ribociclib, and they have similar efficacy. So of course, I will not detail the results of all the trials which were performed those last 5 years, but the most important is this, this figure. You have to consider the adjuvant treatment of patients with luminal tumors. What you can see is that the risk of relapse is around 50% during 5 years, and then 50 remaining percent. And in the patients with a higher risk, I mean, node involvement, for instance, you can see that surprisingly, the risk is higher between 5 and 10 years. And so you give an adjuvant treatment, chemo and hormone therapy, and we consider that patients who will relapse during the 2 first years are hormone refractory. When they relapse between 2 and 5 years of adjuvant treatment, and again, during 1 year after completion of adjuvant treatment, they are considered as having intermediate hormone sensitivity or partial hormone resistance. And patients who will relapse 6 years after having started their adjuvant treatment, or patients with de novo metastatic disease are considered as having full hormone sensitivity. Why this definition? It's quite arbitrary, but I would say it's the definition which was commonly accepted in all the randomized trials we have here. And as you can see, the Bolero-2 trial was done in this population of patients, hormone refractory and mainly intermediate sensitivity. Paloma-3, mainly intermediate sensitivity. Monarch-2, intermediate, but also around 15% of patients with hormone refractory disease. And Paloma-2 with palbociclib, and Mona Lisa-2 with ribociclib, and Monarch-3 and also the Falcon trial were done mainly in patients with full hormone sensitivity. In the trials performed in patients with intermediate sensitivity or hormone refractory tumors, the combination of the CDK4/6 was with fulvestrant. And in the other category of patients, the combination was with an aromatase inhibitor. And the results are, of course, very different because the best prognosis population is the full hormone sensitivity population, and the PFS in this population is around 24 to 30 months in the combination arm versus 14 in the aromatase inhibitor arm, which is very, very, very interesting. And in the other category of patients, the results are, of course, not as good, and the PFS is between 9 and 11 months versus 4 months only with fulvestrant alone. In this context, some group of experts, such as NCCN, recommended to do hormone therapy as long as you can. Continue endocrine treatment until progression or an acceptable toxicity, and at progression try hormone therapy again and again and again, except in case of symptomatic visceral disease. So it's, of course, it's interesting to test hormone therapy as long as you can, but don't forget chemotherapy. First, I would like to mention that this definition of hormone refractory patients, which seems to indicate that you probably have limited or no efficacy by using hormone therapy and CDK4/6 inhibitors, I think it's an arbitrary definition. We have absolutely no data showing that you have poor results in this category of patients as compared to the intermediate category, for instance. And I would like also to mention that if you give an aromatase inhibitor such as exemestane or fulvestrant after failing of an aromatase inhibitor in the adjuvant treatment or either in first line, you have very bad results, only 4 months of median PFS in this context. So, okay, you can try hormone therapy and hormone therapy and hormone therapy, but don't forget chemo. Another definition is visceral crisis. What is it? Sincerely, we don't know. And ABC says it's a severe organ dysfunction as assessed by signs and symptoms, but which ones? Laboratory study, for instance, increase of liver enzymes, and a rapid progression of disease. So it means that you worry about your patients. And in this context, they say we are seeking a more rapidly efficacious therapy, particularly since another treatment option at progression will probably not be possible. Also, I'm okay, but we have no data showing that chemotherapy will act more rapidly than hormone therapy, particularly in combinations with CDK4/6 inhibitors. When you look at those results coming from MONALEESA-2 with ribociclib, of course, the time to response, the time to obtain more than 30% reduction of the tumors will be around 6-7 months. Okay, but when you look at the tumor shrinkage, not the partial response, but the tumor shrinkage, which is meaningful for your patient, you can see that you have responses at the first months from a practical point of view. And so I'm not convinced that chemotherapy will act faster than hormone therapy or the combination of hormone therapy and a CDK4/6 inhibitor. So in the absence of validated biomarkers, except PI3 kinase mutation for alpelisib, the choice is mainly guided by clinical considerations. In stage 4, de novo, or with a late relapse, high hormone sensitivity, and with a visceral involvement, we know that tamoxifen is inferior to an aromatase inhibitor, which is equivalent to fulvestrant, and which is inferior to the combination of a CDK4/6 inhibitor and an aromatase inhibitor, and which is also equivalent to the combination of fulvestrant and a CDK4/6 inhibitor, as it was recently shown in the Parsifal trial, which I did not show. When we have a stage 4 de novo or a late relapse without visceral involvement, you know that an aromatase inhibitor does better than tamoxifen, probably not as good as fulvestrant, but fulvestrant is inferior to aromatase inhibitor plus a CDK4/6 inhibitor and has the similar efficacy as a fulvestrant and a CDK4/6 inhibitor. Perhaps in a very small subpopulation of patients with de novo metastasis or very late relapse and with no visceral involvement and with an oligometastatic or an isolated bone metastasis, perhaps, or elderly patients, perhaps there could be a role for hormone therapy alone and fulvestrant in this case. And I would like to remind you that when you have very, very indolent diseases, you need to locally treat your metastasis, if possible, even bone metastasis. In second-line hormone therapy, after an aromatase inhibitor failure, the combination of CDK4/6 inhibitor and fulvestrant, if no prior CDK, will give you an overall survival benefit, which was demonstrated in MONALEESA-3 and 7 and in MONARCH-2. So with Ribo and Abema, we don't have seen at that time any overall survival benefit with palbociclib, but it's perhaps due to methodological issues. Don't forget chemotherapy. In the Pearl study, the combination of fulvestrant and palbociclib was not different from capecitabine. So don't forget chemo. Can you use a CDK after a CDK? It's still a question. We have no answer. What can we do after CDK failure? You can give exemestane and everolimus with relatively bad results, around 5 months of PFS. Or you can give a combination of alpelisib and fulvestrant in PI3 kinase mutated patients, as it was shown in the SOLAR-1 trial. And don't forget that chemo will be necessary sooner or later, and hopefully not too late. Just to say 2 or 3 words about chemotherapy, aggressiveness, I mean, the increase of dose intensity or combination of agents, and the use of taxane and anthracycline, etc., etc. We have a lot of trials and drugs for very, very little evidence. And you can see that in this meta-analysis, with many trials, only 13% of those trials have shown an overall survival benefit, which is highly disappointing. So in first line, efficacy end goal, mainly in aggressive disease, when you have visceral metastases, and if the patient, of course, has a good PS, you can give an Antra or weekly paclitaxel or vinorelbine, or in some cases, a combination of Antra and taxane. And if quality of life is the main goal with indolent disease, or depending on the patient's choice, you can use oral capecitabine, oral vinorelbine, and also an interesting way of giving chemotherapy, metronomic chemo with cyclophosphamide and methotrexate. And in further lines, depending upon the drugs previously received by the patient, there is no clear role for a combination. And after an Antra and the taxane, you can give capecitabine or eribulin, as it was shown in the EMBRACE and the 301 study. Just to remind you that a combination of weekly paclitaxel and bevacizumab is highly effective, but we don't have this treatment is no longer reimbursed in France, for instance, unfortunately. In this very, very large study on more than 2,000 patients in real life by the French Federation of Comprehensive Cancer Centers, you can see an important overall survival benefit in real life with a combination of bevacizumab and paclitaxel in luminal tumors. Another issue is the duration of chemotherapy, what we can call maintenance treatment. So you can give weekly paclitaxel until tumor progression or severe toxicity, or an Antra and a taxane and then a taxane alone, or an anthracycline alone, or giving a taxane then capecitabine. What will you obtain? A significant PFS benefit and only a marginal OS benefit. It's certainly not for all patients, probably for patients with aggressive disease, visceral involvement, high tumor burden, hormone resistance symptoms, and of course, if the patient is okay to continue her chemotherapy. So I have finished with this this overview, and I hope you were interested in this talk. Thank you for your attention.